Good afternoon. Welcome to the program, Billing for Behavioral Health in 2018, the top billing changes and challenges that may affect reimbursement. I'm Julie Miller, Editor-in-Chief of Behavioral Healthcare Executive. Today's program is sponsored by the ECHO Group. Thank you to our sponsor and to everyone in our audience for giving us your time and attention today. Before we get started, we do have a few housekeeping details we'd like to review. Please use the Q&A area below the slides to submit a question or a technical issue at any time. You don't have to wait until the end of the program to submit your question. To download the slide deck, please click on the Resources tab to the right of the presentation window. Finally, you can also join our webinar conversation on Twitter by using the hashtag BHELiveWebinar. Now it's my pleasure to introduce our speaker for today, Suki Norris. Suki is Senior Knowledge Engineer at the ECHO Group. She has more than 35 years of experience in healthcare, including healthcare law, managed care, and behavioral health, as well as expertise in Medicaid waivers, meaningful use, and the Excellence in Mental Health Act. She's worked extensively in data analysis, including big data in support of ongoing research. Suki, thank you so much for taking the time to speak with us today. With that, I'll turn the audience over to you.
Thank you so much, Julie, and thank you all for joining. Today we're going to cover just some elements of what this new payment methodology is going to require. We're going to start, I'm going to give you a little bit of a background about ECHO. And then I want to get into the current state of behavioral health billing, and then a focus on the changing direction of reimbursement, sort of where we're going next, or where some of you may have already gone. What are the tools you're going to need to get there? What are the tools of the trade? And square peg in a round hole, it's a little bit of a clever way to say that the quality measures that you're going to be asked to do for that quality part of the new alternate payment methodologies really will be and may be a challenge to you and to funders in identifying the right quality measures. And then a little bit about what you can do to sort of control or manage your own destiny with a Q&A to follow. A little bit about the ECHO Group. The ECHO Group, we've been privately owned since our inception back in 1981. We do business in over 35 states. We provide enterprise software application to manage both the clinical and fiscal side of behavioral health. We also offer a revenue cycle management. As we talk about billing, think about the challenges you face, and those are things that we take on for you. Provide support for information technology, and then fiscal and clinical process workflow analysis. In the past, you really could separate fiscal and clinical when you looked at structures, but in today's world, they really have to be in hand in glove, because so much of your reimbursement isn't going to be tangentially linked to what you do clinically, but really directly linked to your clinical processes. So, and then just a little bit about myself. As Julie said, I've been around this industry for about 35 years, from the legal side, from clinical and process overview, and the billing side. I must have started when I was in kindergarten, because clearly I couldn't have been working 35 years as an adult. But let me go on and give you a little bit of background of where we are now. So we're going to take a hard look at the rules of today, what the billing rules are for the majority of you. Now, I understand some of you may be already into alternative payment methodologies, but to sort of start from a single place, we're going to look at the rules of today. And then we're going to anticipate the rules, or your rules, what you're going to have to do. And rules are probably a hard term for this, but really, if the end result is reimbursement, then it's probably fair to say that these are rules or processes that you really are required to follow. It's not so much a choice. Nextly, the concept of how your technology supports you is going to be of critical importance. If the alternate payment methodologies that we're going to talk about today involve both quality measures and billing measures or encounter related, then really what your software is going to have to do more than it's done in the past to meet kind of that marriage of the two elements. And then finally, I have young kids, so I know this one well, but it's teaching to the test. If there, in the absence of uniform quality measures, you've all had quality agencies and provided quality service. But in the new world, it's not how you define quality, it's really how the National Quality Forum, or CMS, defines quality, which is a new challenge for you and really something that will require, I think in best terms, teaching to the test. So what is the current methodology? Well, it really is fee-for-service. And fee-for-service is you provide the service, and whoever your funder is, whether it's Medicaid or Medicare, they reimburse you. They talk about it as quantity. If you do 10 individual services, you will get 10 times whatever your rate of individual service reimbursement is. Now, you may not always get paid. People hold tight to the money, and there may be denials and otherwise. But your method for reimbursement is based on the quantity of the services you provide. Then came in 2007, 2008, this thing called the triple aim. And the idea of the triple aim was to begin bringing quantity and quality to a single place, which was the person. So the idea was you would get better care for the individual. There would be better care for the population as a whole, looking at the individual as part of a defined population. And when we did that, when we married those two things, we would bring down the cost of health care. And that really it came about prior to the Affordable Care Act, but it was a major tenet of the Affordable Care Act as well, and the major underpinning of the move away from fee-for-service. And then came, in order to sort of make this a little bit more and to bring a little bit more to it, then came MACRA. Many of you may not, Medicare billing may not be your prime focus, but for Medicare billing, MACRA was the Medicare and CHIP Reauthorization Act. And what it did is it took 2 or 3 disparate methods for provider reimbursement that Medicare had in its rate schedules and really brought it into 2 choices. One is MIPS, or the Merit Incentive Payment System, and that's the default. If you're a Medicare provider and you provide over a certain dollar amount and number of client amount services, you will be most likely under the Merit Incentive Payment structure. And we'll talk about that a little, but just to give you an idea, there's still an underpinning of fee-for-service with that, but there's a quality element as well. The second group is the Advanced Alternative Payment method or model. And you hear me, I've already talked about alternative payment model because that's really how everybody is defining anything that moves away from fee-for-service. But in the Medicare model, it becomes a very complex method, and they would expect maybe 10% of people getting Medicare, maybe 15% at the beginning to really adopt the APM, or Advanced Alternative Payment Model. It is those 3 elements together, fee-for-service, the triple aim, that really are beginning that march away from straight fee-for-service to a more quality-based and ultimately risk-based service. So what do you expect to happen, or what the rules of tomorrow? Well, it's a trek. Payment methodologies from the time I first saw managed care, it's been a journey. how people do it, what are the requirements, and this is no different. In putting together the March Towards Alternative Payment Methodologies, 4 categories were identified. And these were, it is believed that if people follow these 4 categories and take a pathway through them, truly a trek, by the time they hit full capitation or full risk, they'll be prepared for it. And what will prepare them are these initial categories. The idea that Medicare has is that nationally, right now, the bulk of payments are in Category 1. They believe that within 5 years or so, the bulk of payments will be in Categories 3 and 4, and very few payments will be in Categories 1 and 2. To help understand that, what I'm going to do now is walk through each of these categories and try and provide a few examples where appropriate as to what they mean and what they do. So the first is Category 1, and that's what you have now, what current is for the bulk, for at least 50% of your reimbursements, if not more. It is straight fee-for-service. The only link to quality, now it says no link to quality, and the only way I would beg to differ is that I would believe that each of you in your agencies have strict quality measures that you follow independent of what the National Quality Forum says, but what you as an agency have identified as what your quality measures will be, your quality standards, your patient care standards. So I don't want, while the model that I'm using here says fee-for-service, no link to quality, I would say that that's really no governmental link to quality, but never want to believe that that doesn't mean that you as an agency have your own links to quality that are very important and should be managed and respected. So Category 2 begins this concept of linking fee-for-service to quality measures. The idea is to do it very slowly. So when they break down Quality 2, they break it into really 4 different steps. The first step is just to provide incentives to improve your health information technology, giving you the technology center to be able to give them the data that they're asking for to provide the care, but get from that care data that you may not currently be storing or capturing. The second piece, and we've seen this a little with macro, Medicare's done this, others have, is to pay for reporting. Pay for reporting is not a quality-based measure. It's just paying you to send a file in. It's paying you to extract the data from a system and submit it up to CMS, submit it to your states to report on the quality measures that they've identified in some way. Again, not looking at the results of the reporting, just at the mere act of reporting. The next step begins the rewards for performance. In most governmental programs that you've seen, the first step is to reward performance, and then they will take money away or they will penalize you for not meeting performance standards. The rewarding for performance would include, bonus payments for meeting certain quality levels, or really just identifying what is defined as a quality performance and then giving you additional monies over and above what is the current fee-for-service rate for meeting those levels. The final piece of Category 2 is a pay-for-performance and a penalty aspect. So now you're going to submit those quality measures against a national standard. If you are above those equal to or above those standards, it will be considered quality performance. But if you're below those standards or can't meet those standards, it's going to be you will be penalized. I'll say this now, and I'm going to be saying it again. nobody takes into consideration what your case mix is, what types of diagnoses you're treating. So you could, and nor do the national standards take into consideration specific diagnostic mixes. So you're going to be judged against if you have I don't mean I'll use some terms just in order to give it. If somebody's dealing with outpatient depression exclusively, and another practice is has primarily dealing with folks who are diagnosed with schizophrenia, they're going to be judged the same way for the same services that they provide. So again, case mix will not be considered, but quality measures will be a national standard. Then we get to Category 3, and it's the first time you'll see the phrase alternative payment methods, or APMs. And this is really APMs that are built on some concept of a fee-for-service architecture. The first one that folks talk about often is bundled services. And bundled services made a lot of sense in healthcare. It was figured out a long time ago by Medicare that if somebody had bypass surgery, there was a certain level of service that was going to be necessary to cover the costs of that treatment from the time of surgery to some point in the future. So the concept of bundled payments came about, and it made sense. The opportunities to move bundled payments into behavioral health, people have talked about doing it with kids diagnosed with ADHD. There's some programs being brought out that are interesting. One is the patient-centered opioid addiction treatment, or also known as PCOT. Some of you may be familiar with it. But really what this defines a period of treatment for folks who are diagnosed with opioid addiction through levels of service and step-down levels for a period of time. So it's a way of reimbursing for those services on a bundled payment, which is a method of new alternate payment methodology. Another place this can be used, or it's recommended or suggested or people have talked about, is with first episode of psychosis, getting to people quick and then providing a set of services that within a bundle to deal with those, to address the needs of the first episode clients. But again, bundled services are probably more familiar to the physical health world. They are looking at ways to bring it into behavioral health. And I will say it's behavioral health specialists who are really looking at ways, not CMS necessarily. So in addition to bundled payments, you're also going to have episode-based, which could be very similar, but may meet some of the requirements. It may be a little bit more specific to behavioral health. Again, we talked about ADHD, things where you can see perhaps the beginning of an episode or an episodic state. The next step is, and with the first part of this Category 3, we'll have those bundles, but again, you're only going to look for the upside gains. If you don't provide services within the terms of the bundle, or you run out of money, it's going to be a downside gain, and you'll share that risk with whoever your payer is. As you move to the second part of Category 3, you would be responsible for both the upside savings if you don't spend the entire amount of the bundle, and any downside, any risk, any amount of money that didn't get covered, any services that were required outside the bundle. Each of these require an element of quality as well. So while they're going to change the way they're going to pay you based on some government-determined diagnosis and then process after that diagnosis, they're still going to look to quality. Are you getting the outcomes? And really quality fits right in, because the question is, are you getting the outcomes expected? Meaning, are you able to treat for within that bundle? The thought is that that bundle represents the best quality for care. So if you don't meet the bundle, were you meeting the best quality of care? And that would be the analysis that might get done. Category 4 is truly the future. Now, you may see bundles next year, you may see quality measures, you probably will. But Category 4 is full risk. And full risk means you're going to get a certain payment for the people that you treat or may treat, and you have to provide treatment within that dollar parameter. Most behavioral health risk-based contracts that I've seen are what we would call condition-specific populations. So you are treating a group of folks, perhaps the SPMI population or an SMI or SED population. People are identified, put into a category, and you receive a certain amount of money for each of the people in the category. In many ways, the methods for paying the CCBHCs is that kind of condition specific. Depending on the nature of what is being treated, it will change the monthly amount or the daily amount that you are prospectively paid for treating those folks. Capitation, in its truest sense, is a per member per month based on a catchment area. So if you have a county and you are responsible providing all services, all mental health services for people in that county, bean counters would determine that, okay, given the most severe folks, the least severe folks, this is the amount for each member you're going to get per month. And how well you do is going to be based on something that's called the penetration rate. Of the people in your catchment area, what percentage are actually seeking services? That you may see much more in primary health care. You may see it more in hospital care. I've not seen much of that in behavioral health where you're given that kind of per member per month. And it's not necessary within Category 4 to be at full risk. This isn't necessarily, like everything else, a pathway from A to B. Here, you could be in A or you could be in B, and both would be considered full risk, and both would be considered the alternative payment methodology that really everything is moving towards as we move through these payment processes and payment systems. So if I haven't really scared you yet or sent you running to the hills, let's look a little bit about what's necessary to get this done, to help agencies be ready for it. What are the tools of the trade necessary to move you through these sections to get you ready for quality reporting and risk-based contracts? The most important tool really is you. You have to understand what is being expected of you, how to marry the processes that you know are important for your agency as against what is expected by the government entities that are expecting the quality measures. How do you continue to provide the care you want to for your clients and still meet those needs? Julie told you, and it's on my biography, I was a lawyer, and one of the first things they teach you in law school is never ask a question you don't know the answer to. This isn't quite as steadfast when I write this here, know the answer before asking a question, but it's a very similar kind of concept. You have to know your agency, what your processes are, what quality measures you really are conforming to, what the cost of doing business is, in order to ask the questions that you're going to need to ask. So you're going to know that you're going to, depending on the answers, you're going to pull out of your toolbox one of the things we just talked about. Is it understanding the cost of services? Is it understanding what your systems will do? Is it understanding what quality measures you really can meet without affecting the quality of care for your clients? And again, to know the answers before asking the questions, you're going to have the right tools in your toolbox. Those are the pieces of data we've talked about, the quality measures, the understanding the cost of doing service. And you have to have technology that is a partner to this. It's a business partner, but your business is providing clinical services. Unfortunately, perhaps for many of you, your business now has become equally a cost-based system in some ways. So you have clinicians, they're going to provide services. You know the services they provide and you know what you charge for those services. But you haven't had to really understand the cost of what that clinician, the cost of the clinician. Sometimes I talk to people and I say it really is as ridiculous as how much does it cost for the air that they breathe? But more specifically, the desk that they sit in, the office that they do their meetings in, the computer that they use, all of those things go into the cost of your agency, and those costs have to somehow be translated to the care that you're providing. So what's the difference between the cost of a group versus the cost of individual therapy? For those, a lot of people call it the nut. So there's a basic cost to doing business. Every day you open your business, there's a cost. How do you manage that across your agency to understand the right electronic record, the right business partner helps you move in that direction, helps you understand how to capture that data, how to save that data, how to report that data in a way that will prove what you already know, and that is that you provide quality service. So early on I said this is all about teaching to the test. Some of you may have kids, and you know that when they're young and they have to take tests all the time, you find teachers really teaching kids how to pass the test, how to do well on those tests, because that was a definition of schools that were progressing, that they had kids who were scoring X on tests. And it got away from sort of really, what do you do in school? You learn things, you expand your knowledge. You don't just learn what the test is going to tell you. You want to learn more. So now but to get here, some interesting concepts have been raised. My favorite is that value equals better care. I am still looking for proof that statement alone is true. Value doesn't equal better care. Finding value may expand care, may make more care more available, but it doesn't necessarily mean better care. And yet, I've read hundreds of articles that somewhere in the article there is a statement that somebody had to start a long time ago that said value equals better care. And again, what they've done is, thinking about value equals better care, they set up a fight between quantity and quality, as if quality means that quality is better than quantity, that there's no relationship between quantity. And even to say quantity as it's related to behavioral health services leaves me a little cold. But that's how they've done it. That's what they think fee-for-service is. The payers would define fee-for-service. If they think somehow that fee-for-service means that you're going to go out and do every service you can do without regard to whether it's good for the client or not. But if we bring quality to it, that's going to make you slow down and consider what's best in the best interest of your client. I would suggest to the folks who said this that behavioral health providers have been thinking about what's best for their clients as long as they've been providing care to their clients, because that's what they do. That's what they have to do. It isn't about quantity. It's always been about quality. Can you provide quality services to those folks that you treat? And that may be a quantity of services. It may be very few services. But really, to put those two together is to seemingly not really understand what the role of the clinician is in the clinical workforce. Quality care is evidence-based. There's no doubt about that. That's where the industry is headed, and that's where perhaps it should be, that you want to use evidence-based care. And then finally, in a real system, in the perfect system, in the triple aim, clients and providers are paramount. That should be the goal of the alternative payment methodologies. It should be that you can use evidence-based care and that the clients and providers are paramount. But what is the test that you're teaching to? And this is where the people I work with tend to bring a soapbox over to my desk, because I tend to get on one when I talk about this. The quality measures are supposedly based on quality. Quality is represented by measures, but measures use both claims data and data from your electronic health record. The minute you use, and what they're using is claims data that may be 2 years old. So they are determining some of your quality measures not on the true record, but on your claim. And in that claim 2 years ago, maybe you weren't quite as precise with the diagnosis. Maybe something else wasn't quite as precise as it should have been. If you knew that whether or not that the quality measure would be met would be based on that data. So one of the takeaways is you've got to pay attention to how you record your services, how you represent them, and what service you're representing against what an expectation of quality is for that service. Something about measures that also is a little bit frustrating to me. There are 653 endorsed measures for quality. Of those, only 55 are behavioral health conditions. And of those 55, only 9 are true outcomes measures, looking at the outcomes of the services that you provide. And perhaps worse yet, only 15 relate to substance abuse. And finally, there are no outcomes that address social and behavioral determinants, elements that are really important, I think, in determining the quality of services that you are providing. And so you already start behind an 8 ball, and the reality is that there's a hidden truth behind quality measures and how people are looking at quality and how people are looking at risk. And that is that there is a belief amongst policymakers that integrated care is the way to provide the best, most quality-driven care. But when they define integrated care, they never say integrate physical health with behavioral health. They always say integrate behavioral health with physical health. The problem in that, I see, is that some really well established agencies, behavioral health agencies, could work with physical health, but perhaps they are better off served by not fully integrating, and they should still be able to manage against to consider quality and to be considered a quality agency. So some things about that you should know that you might want to be doing now. First off, currently over 50% of states are participating in some kind of delivery system modification for alternative payment reimbursement. Now these might be, there are 7 states that are doing delivery system reform incentive payments, also known as DSRIP. There are 17 states that have Medicaid accountable care organizations. That was a function that came out of the Affordable Care Act. 7 states are using bundled payments. All of this is for behavioral health. And then 15 states have added alternative payment methodologies into the MCO contracts. And that's one of the ways you're going to see this very often. It's going to come in through your MCO contract, and the managed care entity is going to be given the ability to put the entities it contracts with, the mental health agencies, at risk for payments and to demand certain quality measures. So the next question is, do you know what your state is doing? If you're one of the states, and if you're one of the 25 states, then you might know, you should know. But what your state is doing is prepping for alternative payment methodologies. Either it may be planning to expand what it's already doing, or it's going to enter into contracts that will include alternative payment methodologies. Often this comes through your the 1115 waiver, which would come out of the state Medicaid office. But somewhere in your state are going to be the indices that will tell you what direction the state is going. It is not likely, and in working, in talking to, and in engaging with the state Medicaid, the National Medicaid Directors Association, it's pretty clear to me that all states are looking at this. Some states are further along, but you should know what your state is doing, and you should then follow those activities pretty carefully. That may be looking what waivers are submitted. CMS makes them available even when they're pending. So I can go out and look at any state's waivers that haven't been approved yet, and I can see the history of stakeholder involvement and what's gone back and forth. All of that is public record. You want to watch for the managed care contracts that are entered into by your state, because it is likely in this day and age that they will have some kind of movement towards capitation or risk, something in probably Category 4, as we talked about earlier. And then you want to volunteer. Agencies, mental health agencies, are almost always welcomed. I've never actually seen them not welcome to be stakeholders as the states work through these various methodologies, because you're the folks who are going to be affected by it. So get a seat at the table and bring with you some of the things we've talked about. When the slide deck gets uploaded, there'll be a page of a bibliography, and it's a start at some of the documents that are out there to explain this to you even in more detail. But be armed with that kind of information, because that will help you inform help you inform that discussion your state is having. And then you have to monitor the development of new quality measures. New quality measures are coming out, they're being worked on in many ways, and you have to monitor those. There's a task force, there's a behavioral health task force. There are entities like the Kennedy Forum that pay a lot of attention to those. Watch those, see if you can become a member of the task force, or at least provide comments. These are the National Quality Forum follows the same as any legislation. When they have a new plan, a new document, they invite comments. Watch those measures. Make sure that the measures are behavioral health specific, that they're not focused on medical as it integrates with behavioral health. If you look at things like functional and behavioral indices, those are real behavioral health indices. The absence of those is a problem, because so many measures are really reliant on a medical diagnosis, so that the behavioral health piece of it is based on a medical diagnosis, and then the behavioral health diagnosis is a follow-on to that medical diagnosis. Behavioral health outcome measures should be exclusively behavioral health focused. Then there should be a set of measures that are integrated, that respond to that Venn diagram, if you will, between physical health and behavioral health. And then there need to be a separate set that are just behavioral health, that are just physical health. In that way, every provider will have the ability to show quality based on measures that are totally within their control and their oversight. Even with that said, the challenge will be, what do you do, how you manage your practice, your clinical processes that have been in place sometimes for 50 years, sometimes for longer, against a workflow that will have to lead towards outcomes. Because even when they are behavioral health outcomes, even when they focus exclusively on behavioral health, it will still challenge you to remodel your provision of services to meet the specific needs of the outcome measures, and therein lies the truth. even if if there were 100 measures, and even if 100 measures were focused exclusively on mental health and substance abuse, you would still, to one degree or another, have to teach to the test. It's not always that a person being out of a hospital, that it's wrong for a person who's been out of a hospital for 30 or 60 days to go back into that hospital if something traumatic occurred and they need to be in a hospital for best care. And yet that is a measure that you're judged against. Some of you have practices that don't rely on medicine, on Western medicine. You have every right to have those practices. But in the quality measures, if somebody is diagnosed with depression, there's an expectation that they would be put on medication to move through that. The truth is that you will have to work, and why when we were talking about technology, the concept of partner, you'll have to work with people to figure out how to reassess your treatment processes against those treatment outcomes that you're willing to work towards. Because at some point, alternative payment methodology is going to become payment reality in your agency, maybe for 10% of it, maybe for 50, 75, or 100%. And there will come a day where, except for truly outlier-like services, all your payments are going to come through an alternative payment method of some kind of risk-based. And the minute that is said, then quality measures that are managed at the state or federal level will be the quality measures that your quality is judged by. In truth, quality will always be judged by how the client feels about the services they provide. But in a payment methodology world, in a payment world, it's not about the client. It's about the agency and the quality of care that the agency is providing to all of its population. And that's the important thing. You can provide the best care for each client, but if when you aggregate the measures, you're not at the level of that the measures are expecting, then what will happen is you will suffer a penalty. You may not be fully reimbursed. And one last thing that I think is something you should know about, and that is that when you are capitated and you have a certain amount, there is some fear at the federal level and at the state level that you will stop providing care in order to pocket that money so that money won't go straight through to services. Now, I think that that's probably not likely, but so there will always be additional requirements that you show how much of the money that you're getting in capitation is actually spent on the provision of care. And there will be expectations that is 83%, 85%, 95%. And it's the final thing that you need to know your system has to be able to manage. Can your system tell you that you have spent at any moment in time that you are on course to spend 87% of your capitated dollars or 95%? Because that's going to be a very serious measure that you're going to get judged by. And so if I haven't scared you off, if you haven't been doing this forever and saying, yeah, I know, it's not fun, but I'm doing it, then I'm really am happy to take questions. And just a little reminder, what we've done today is we've talked about the rules, talked about what may be coming down sooner or later. We've gone over how to manage your technology and that information to be able to meet these demands. And finally, what the challenges of quality measures will bring to your agency. So thank you very much for your time, and I'm happy to answer questions.
Fantastic. Suki, thank you so much. I would like to remind everyone in our audience that you can use that Q&A area below the slides on your screen to submit a question at any time. And just a reminder, if you're interested in downloading the slides, they are available in the Resources tab to the right of the presentation window. All right, Suki, let's dig in. Here's a question for you. How do providers manage multiple value-based programs when they have multiple payers? That sounds like a huge task.
Yeah, what you're going to have to do depends on your system, but most likely what you're going to have to do. Well, first, there's a basic question. If a client can only be in one, then it would be based on sort of how you assign a payer to a client. Where I see complexity often is where a client is really involved in more than one of the payment structures, in which case you'll still have pretty much alternate payers, and there's going to have to be some differentiation. As an example, I may have some services that are going to be provided through an integrated care model. I'm going to have others that are part of a risk-based model of some sort. So I have to be very careful how my services are identified and then where I send claims to, because even in a capitated model, you're going to send encounter or zero-based claims, shadow claims. So you have to be very careful that you segregate the services to the right, in this instance perhaps shadow claims, so that you're managing your costs appropriately for each of the different programs. And I know that there are a couple of states where that's a very real problem that I've spent a fair amount of time looking at, so I do empathize with the questioner on that one.
Great. And someone in our audience is asking, is there a timeline for all of the states to move to value-based payments?
No, there is no specific timeline yet. It's at 50%. As I said, there are 50% of states are doing it. The goal, I believe, of CMS is that somewhere in the next 5 years. Now, I don't think it's going to be that fast, so it hasn't been specified, but here's what I would say. Given the challenges that we're looking at with healthcare and some of the things they're doing with Medicaid, it could happen very fast. If, let's say, Medicaid block grants go back to states as some folks are thinking, it could happen really fast. If I had to guess, you're going to see it hit population. It's going to roll into one population after another. The last population I think it's going to be fully engaged with is the drug and alcohol population. But I would say there is no specific time frame for Medicaid, but Medicaid directors are looking at 5 years.
Oh, that's good information. You had mentioned earlier in one of your slides that 15 out of 653 measures are related to substance use disorder. Can you provide an example of what one of those measures might be?
No, I'd have to send an email because I don't have the measures with me. There are measures that deal with. I don't have the specific measure with medication administration, treatment based on the nature of a diagnosis. There are measures that deal with if a person is diagnosed with a substance abuse that a depression screening is done. I can get the exact measures, but that's in a different place. But those are a couple of examples. So one is looking at the comorbidity or co-occurrence, and another is looking at the specific treatment steps that you would take in medication for certain in certain programs.
Okay, and you had mentioned the need for providers to know their actual costs for delivering services. It seems like a difficult task. Do you feel that providers are doing a pretty good job of that right now?
No, I think it's very new. I don't think so. I think that providers, historically, it hasn't been the focus of how providers manage how the agencies are managed. I know that when I worked with some folks who were going into the CCBHC experience, trying to do the original cost analysis became very difficult because it's an amorphous task, to be sure. You don't know the cost of each desk, the cost of each of sort of each piece of space. But it's something that maybe their accountant knows, but I don't think that the management of agencies has really been focused on that. It hasn't been the focal point. They haven't been asked to know that as much, so it hasn't been the focal point. It's doable. Other industries do it a lot. I came from the legal world, and we did it all the time. But for behavioral health providers, it's been sort of farther away from sort of how they look at the cost of doing business. So it is something that, and the reason you need to know that is because if somebody's going to tell you you're a risk-based contract, you have to know what it costs you to do those services. And it's not going to be just, I'm going to do 10 outpatient and 3 group services. There's more to the cost of doing those services and supporting your agency than just those individual services.
Okay, great. And another question from our audience. Does the APM apply to both in and out-of-network providers?
Depends on the APM. Oftentimes what's happening, I know in our state, I live in New Hampshire, if you're at a particular agency, you're going to be in part of the group. If you get a service outside of it, there's going to be a fee-for-service allotment for that. It could be as difficult as if the service is part of what in-network was supposed to provide. So you're in a world where you're responsible for all services for a particular diagnosis or level of severity. And you need that person, because you don't have the service, they have to go someplace else. It could be that your cap rate has to cover the cost of that, so you would need an MOU, a Memorandum of Understanding. Some states are less draconian than that and say, okay, if you go over here outside of network, in essence, we'll pay that. We are going to reimburse that at a fee-for-service rate. I've seen both, and certainly the fee-for-service is an easier way of handling it.
Okay, and someone in our audience is asking, what is the best resource for help in defining the quality measures?
The best resource? Well, National Quality Forum, let me put it this way, in the bibliography, I included the National Quality Forum's proposal for behavioral health measures. They also in there have their link. They are the managers. The National Quality Forum is the management or manager of all approved quality measures. So the first thing is to go out there and see what those measures are. I would say I'd ask you that you also look at the behavioral health quality measures because they're interesting. And then keep an eye on them because they do invite comment. They do invite people to get involved. And you also know from there what entities are proposing the measures. Is it NCQA? Is it the CMS? So it gives you places to go to look. But the measures they attempt towards a very scientific methodology, but they are required to get stakeholder involvement from outside the scientific community. So see what they are and see if from that document you can sort of branch out and get more involved, or at least keep an eye out on when they're accepting comments and be able to make those comments and get your voice heard.
Well, that's good advice. That is all the time that we have for questions today. I want to thank Suki Norris once again for an excellent presentation, and I would like to thank our sponsor, the Echo Group, for making today's program possible. Finally, thank you to everyone in our audience for participating today. We do hope that you'll join us again in the future for another Behavioral Healthcare Executive webinar. This concludes today's presentation.